Good afternoon and good morning. My name is Joanna Galari and I work at the LEAP Center. The LEAP Center is a new interdisciplinary hub established at the University of Global Health Equity. By bridging academia and care delivery, the LEAP Center supports the identification and scaling of evidence-based, equity-focused innovations to improve health systems and address the needs of underserved communities. The Global Health 3.0 webinar series maps out what we've lost since the dismantling of USAID, what financing for health and health education will look like in the future, and what local and Pan-African initiatives we need to sustain progress and to address emerging challenges. For your information, we are recording this session and the recording will be available on UGHE platforms. I welcome audience members to post their questions in the Q&A section or the chat. Our moderator will choose written questions in the chat to pose to our panelists. I will now hand it over to our moderator, Dr. Philip Cotton, the Vice Chancellor of UGHE.
Thank you very much, Joanna, and welcome to everybody to this webinar and this series of webinars, as Joanna says. And thanks too for the LEAP Center for organizing this important conversation. And if you want to find out more about the LEAP Center, then please pop on to UGHE's website. At UGHE, through the work of the LEAP Center and our commitment to equity-driven system strengthening, we're deeply engaged in understanding how global health architecture shifts in moments of transition. These conversations help us consider how Africa and the Global South can lead in shaping what comes next. Now, on June the 3rd, 2025, the US administration formally requested the rescission of more than $8.3 billion in foreign and global health assistance. By the end of that fiscal year, global development assistance for health had fallen by 21%, driven in part by a 67% contraction in US financing. But it's not just money that's lost. Analyses from Chatham House, the Center for Global Development, the International Rescue Committee, and Globalization and Health point to the erosion of critical technical and institutional capacities. Today, we're going to discuss some of these things. And I'm honored to be joined by three giants in their field, three really totally impressive friends of UGHE and, of course, PIH. Anna, Olubenga, and Sheila. And what I'm going to do is turn over to each of you and ask you just to introduce yourselves to the invited audience here, your name, your role, and in one sentence, maybe why today's conversation matters to you. I'm then going to turn to each of you in turn and ask you a question. After each of you have answered that question, we'll move to the audience and invite questions and answers from the audience. And then we'll come back to you for one final question. So I'm going to go to Anna and then to Olubenga and then to Sheila. Just introduction, name, role, and why today's conversation matters to you. Anna.
Thank you so much, Phil. Good morning, good afternoon, good evening to all those who have joined us today. My name is Anna Bodipo Mbuyamba. I'm an executive global health advisor, was a former health officer director for USAID in Rwanda and Burundi, also deputy mission director in the past, but been working in the field of global health for over 20 plus years. I'm excited to be here as a partner with other Pan-African leaders and innovators who are seeing the new opportunities that are emerging in Africa. And so this dialogue for me is important because it's an opportunity to share and to begin thinking collectively of how we move forward. Thank you.
Thanks, Anna. Prof.
Good afternoon, everybody. Morning from New York City here. Benga Ogedegbe. I'm a professor of medicine and population health at NYU Langone Health, and I direct the Institute for Excellence in Health Equity. I'm an internist by trade, originally from Nigeria. So this is very important for me because it's a lived experience. Most of my work in the global health space has been okay for the past 20 years, really focused on developing strategies to improve health outcomes, particularly in patients with cardiovascular diseases, and also to build research capacity such that scientists can do relevant work on the continent. Thank you.
Thanks
for having me here.
Thank you. Thank you, Sheila.
Hi, good morning or afternoon. Thanks for inviting me to be here. I'm Sheila Davis. I'm currently the CEO of Partners in Health, but I've been at Partners in Health for 15 years with many, many roles, and have worked as a nurse for over 35 years. So I'm excited to be here and be with this great panelist. I think it's now more than ever, it's critical that we join forces, and we've tackled really challenging things as a global health community. This is a different kind of pathogen, maybe than we've tackled before, but I think us working in concert together and having open, honest conversations is the way that we can move forward and try to continue to care for all the people in the world that we know are the most deserving. So thanks so much for being here.
Thank you, Sheila. Thanks. And Anna, I'm going to come to you first. You know, much of the discourse has focused on the funding losses. But help us understand what non-financial capacities, technical standards, rapid response platforms, regulatory support are at greatest risk of disappearing with the disappearance of USAID.
Thank you, Phil, for the question. You know, it's a question that I think actually kind of raises some concern for me, particularly with the thought that things have disappeared without USAID. And I want to challenge us to think a little bit differently. I think we actually are in a time for a shift in paradigm of how we see the development landscape and changing the ideas about how the void should be or can be filled by certain people or institutions. We need to rethink and reimagine how we're working. And so with the idea that USAID has disappeared or the reforms or the different platforms that were created have disappeared, I want to challenge us and say, well, actually, they're still there, but the people who work for USAID or the individuals who are working in the development space of these last. So the question that I have is reformulating how we work, how we communicate with each other, how we see ourselves. I think it's time for a renaissance of thought and action. We have African nations, civil society organizations, local enterprises in Africa that need to rethink and renegotiate from a position of strategic value and dependency, and not dependency, excuse me. And so USAID may, as an institution, be no longer with us, but the people that participate in the institution, that work in the institution, that work alongside the institution, and many others are still here and want to continue to engage. So the question is, how are we tapping into these resources of individuals, of capacity, of knowledge that is here, but just needs to be reformulated in a different way, or we need to think about how we work together. When I think about the work that I've done over the last 20 plus years with USAID, I have many colleagues across the globe who are the epidemiologists, the statisticians, the financial analysts that know their work and know it well and have worked alongside of some of our local organizations, some of our international organizations, some of our multilateral organizations. And so now the question is, although this institution called USAID and many others are going through these shifts, how can we re-engineer ourselves? How can we look to each other as opportunities to collaborate differently, change the mindset of what it means to be working in the field of global health and development? How are we engaging with private sector, government, civil society organizations, and capitalizing on these talents that, unfortunately, in the case of USAID, were let go because of policies and different viewpoints, but are still needed. So I don't feel that things have been lost per se. Now, of course, when you look at statistics, there are losses. And so I don't also want to minimize the fact that their lives have been lost, People have suffered. I also want to say that let's not let this situation be a barrier to what can happen. I think there is space now available in a very different way than we maybe have ever imagined for us to see ourselves differently as practitioners in the public health sector. And I really want us to, here on this call and after this webinar, really think deeply and think about how we can be creating more alliances with each other through governments, through universities, through civil society organizations, and share the knowledge that has been built over these last several decades. So I think it's evident that true collaboration and partnership is going to be key to making that happen. And that's the other point I think is important, that um, is that we have to reimagine what our partnerships look like, that they're mutually respective partnerships, that there isn't the donors here and the governments here, that there's some equality being seen as the mutual benefits of how we work and collaborate. So I know, again, the question that you posed about the losses of what with USAID no longer being in the space um, is felt by many, but I also want to challenge and say that we might have stepped away for a little bit, but there are people, particularly local, my local colleagues, who have far more talent, re-galvanized in a new dynamic that we can be creating now, and out of the aftermath of the situation that we're facing.
Anna, thank you. Thank you for bringing so much energy to start the webinar. Thank you. I'm going to turn to Prof now. And Prof, here's probably one of the longest questions you've ever had in your life. And I'm going to take a deep breath as I ask you this. You know, from an academic perspective, what is the real loss to global health knowledge and innovation if USAID's influence diminishes? Not in terms of dollars, but in terms of lost learning platforms, implementation research ecosystems, and long-term data infrastructure that academia has relied on. And which of these losses would be hardest to rebuild without a large bilateral actor? Over to you, Prof.
That's actually one of the longest questions in my existence, but it's a great question because it really touches at the heart of everything we're talking about here. And the way I would characterize this is that no question, just to be clear, as Anna pointed out, and as you pointed out in your introduction, we've lost a lot. But the real loss, in our opinion, at least from the academic perspective, is that three things that we've lost momentum on. The momentum on what I would call the beginning of the work of academic global health, whereby we began to look at the decolonization of global health. And that talks to the issue of equity, right? So that's important. COVID shone light on that. We had a huge momentum post-COVID, and then that died, right? Just earlier this year, barely 6 months ago. The second thing I think we lost is the momentum around increased funding for global health. Not so much funding for global health, but funding to address the scourge of non-communicable diseases, particularly in the field of implementation science. So I'm Nigerian. I was raised in Nigeria. And when I think of growing up in Nigeria and coming to the US about 34 years ago, and really getting trained on 3 continents, in Europe, the US, and in my country. What we focused on for the past 20 years is infectious diseases. And what we began to see, right, was through the HIV pandemic, HIV epidemic, we had built structures in Africa that we can use to create service integration for NCDs. We lost all that. We lost the momentum of how we're going to build that. And then finally, if you look at data post-COVID, you see an unparalleled increase in the interest of young folks in global health. that momentum was also stalled immediately. Of course, it's not just the USAID issue that we're talking about here. It's also the idea, the impact that had. There's a chill factor on really interest in global health, interest in grad school, interest in public practice that Anna talked about. So that to me are the things that are very important for us to think about. And then when it comes to which aspect of this will be hardest to rebuild, again, I'm framing this not as a short term. I'm framing this as a loss in momentum. I think the hardest thing to rebuild is not so much the platforms where we do work on implementation science. I mean, I take Nigeria as an example. So Professor Ezanolue from Nnamdi Azikiwe, University of Nigeria School of Medicine, actually leads the Nigerian Implementation Science Association. Think about that for a second. We have countries now driving implementation science. And that's important. I think the greatest thing that we need to rebuild is, and that we really need to focus on, is the habitual dependency on external funding. I think to me, it's a very important thing to think about. When you look at most countries in Africa, 39%, just let us settle for a second, 39% of the funding for health is from external donor partner groups. You can't make this up. This is the only place where we see external players funding health systems. So to Anna's point, we're approaching a place where we have to reimagine, if I may, the way we think about how we do the work we do today. And I think we're going to have to really form new alliances. Not just that, we're going to have to really begin to rethink this dependency, because as the great Malian philosopher Ampatiba put it, the hand that gives dictates. So at some point, we have to understand what is the consequences of really totally depending on external funding. And then finally, I should say that, in my opinion, in all of my decades of life that I've lived as African, I don't know that there is any country that has achieved prosperity through charity. If there's any, I'd like to know where that country is. Maybe that's the next place I should be going to. Because at the end of the day, if we don't own it, we can't shape it. If we can't shape it, then we can't have the impact we're looking to have. And so let me end on a very positive note to this question. I always see the glass half full. I think we're at a point in life where, at least in the global health life cycle, where we have to think about what we've learned in the past 6 months, maybe 8 months. What I'm seeing across the continent is a growth in resilience. Look, Africa didn't collapse, right? We thought the COVID pandemic was going to bring Africa to its knees. Didn't happen. I think we have to understand we've built some structures already in place. So that's important for us to understand. I think there's a Chinua Achebe quote in the book, Things Fall Apart, where there's a bird, and the bird said, "Since men have learned to shoot without missing, he has learned to fly without perching." So what I'm seeing is significant adaptation of most countries to the current, conditions. And that's important. The second thing is we have a new generation of global health scholars who also are pursuing global health, not because of the funding that's available. Anybody still standing in the field today is because it's a passion for them. And as you all know, if we're passionate about something, it's easy for us to actually deal with failures and with setbacks. And then finally, I think governments have woken up to the idea that they're going to have to co-create solutions. They're going to have to co-create the problems, design the solutions, and hopefully, that importance of ownership is something that will lead us to where we need to be. And I think Eleanor Roosevelt put it very well. It is far better to light a candle than to cross the darkness. So I'm very hopeful that, with all of the ways we rethink global health, there's actually light. And that light is what we need to follow in how we do this work.
Prof, thank you very much, and thanks for reminding us of the power of writers such as Achebe in what you said. And I'm going to get that quote from you a little bit later because I haven't scribbled that down in all my readings over the time. So thank you, and I'm going to go to Sheila, Dr. Sheila Davis. CEO of Partners in Health, to ask this question. Sheila, from PIH's vantage point, accompanying health systems, what has this shift meant for patients, supply chains, community health workers, and ministries of health in the countries that PIH supports? And which of these losses cannot be quickly replaced by other partners?
Yeah, thanks, Phil. I think, first and foremost, we tried to look at what would impact patients from day one. And I represent a phenomenal 18,000 people around the world who are truly the experts in global health delivery. And so those solutions and nimbleness come from those teams that have had many decades of experience in trying to deliver healthcare where not all resources are there. So, looking at what the impact would be and moving things around, moving money around, moving staff around as much as possible, obviously is always the first place that we look. It was clear that regardless of how much money PIH got from the USG or other multilaterals, we work as part of this really complicated ecosystem. So unlike many organizations who I think set up parallel systems, we support and accompany health systems themselves. So it really didn't matter how much PIH lost, it mattered how much our ministry partners lost, and other partners who were also part of this system who had to pull out or leave or lay off large amounts of staff. So I think it became clear how dependent we all are on each other in a beautiful way and a way that's also complicated. And a lot of the information is still being figured out in terms of who funded what, because there were often many layers of funding that went to a minister from not just health streams, but from other streams. And even some ministry colleagues weren't sure exactly what was covering what. So that's also a problem. And I think, as the other panelists have pointed out, that system we were in was not a perfect system by any means, and we can use this opportunity to rebuild it. I think we also knew that we'd be asked to fill a lot of gaps and that we couldn't fill all the gaps that were there. So I've tried to work with ministries, because we work so closely embedded in ministries of health, to look at what tools we could help ministries use to try to quantify commodities that were going to be lost. Malaria got hit very quickly, very fast. HIV and TB, that's been a web as well to untangle. So to try to figure out what is the actual need for these certain commodities, and then on a global scale, what global pooled procurement mechanisms could there be to try to fill some of this gap that exists. Excitingly, and as a longer term goal, that's where there should be much more drug manufacturing happening on the continent and in other places. So this is that we can't just address the emergency in front of us and to try to eliminate suffering, but also how are we trying to move long term to build a different system and be part of a different system. We also know that we have to work with what we have, and regardless of how we may feel about the America First Global Health Strategy, the one good thing is they really highlight frontline health workers. So how do we live into that and really highlight community health workers and frontline health workers, which have always been the backbone of PH's work around the world? With that also comes some fear that money is going to be just pulled and allocated differently to kind of chase the money, which is what the donor community has set up over decades of. To get funding, you have to do exactly what the donor wants to do. So that has contributed to not having a robust health system. So we're at a critical point where we have to make sure that doesn't happen again, or the fragmentation is going to get, I think, even a lot worse. I think in terms of who's going to step in, and this question, I think all of us get asked a lot. And I had my board meeting a couple weeks ago, and that question always gets asked of who's going to step in. And no big partner that I can see on the horizon is going to step in. Although that would be phenomenal for short-term filling gaps, because there's suffering happening today that we need to address, and we can't forget that. But in an ideal world, that isn't how we would replace the system. And I think Anna and Prof have really talked about that. This is the opportunity to shift the dynamic. It's a paradigm shift. This is the time that, shame on us if we build and recreate the same system that really did not benefit everyone in the way that it should have. So I think our challenge is to how do we address this immediate suffering that is there and will continue to unwind, and how are we building a different system? And there's not going to be just one answer of who's going to step in. So it is going to take what others have talked about, collaboration and partnership in a different way. And I think also centering the power, not in New York, not in the US, but centering the power really where the expertise lives and where the care is being delivered.
Thanks, Sheila. Thank you so much. And Anna, Prof, and Sheila, lots and lots of things in the chat. You can see the chat yourselves. Lots of affirmation and celebration of what you've been saying. Lots of questions, and we also have questions in the Q&A facility. I'm going to try and bring together a question by Alphonse and Samudragupta to all of you, and I'll come to Prof first, and then I'll go to Anna, and then I'll come to Sheila. And here is a question. It's several questions. How can we avoid getting into a situation like this again? It appears that the principles of collaboration and mutual respect, which have been honored for a long time, were insufficient. What did we miss? As individuals in the medical profession, what should we learn from these global health issues? Lots of questions there. Maybe you pick up on one or two of those assertions made by our audience. Prof. Oh, you're muted. We'll need to get somebody to unmute you.
I think it's a great question, because ultimately, we have to live from past experience. Mm-hmm. So I will pose the question differently. Mm-hmm. Did we really have equality in how we co-design problems, or how we co-design solutions for the problems? So the way we have to think about not getting into this again is to truly take what I call a very clear, democratic documentation of the policy shifts that has happened in the past 6 months. And I think if we don't document it or memorialize it, then history will repeat itself again. I'm old enough to understand that. I think Sheila talked about this. When you have accountability that is unilateral, whereby I'm going to give you money, right? I dictate the accountability for you, but I'm not going to be held accountable to actually making sure the funds are provided. Then we're going to have the same problem reimagine again. So the way we get out of this, to me, is let's memorialize the policy shifts that has happened. Let's memorialize how governments are beginning to thrive, not thriving, survive. There's a comment in the chat box saying that. And then let's then understand, what are we doing well now that we can leverage? So in my opinion, the way to begin to think, there's the Abuja Declaration, I think it was 2008 or something. President Obasanjo was president of Nigeria at the time, where African governments pledged to increase health funding by 5 to 15%. Probably only 1 or 2 countries, I won't mention names, have actually held on to that. And if you look at the impact of the USAID funding, that we're talking about, it didn't affect those countries that much because they are stepped up. So I believe that for this not to happen again, three things have to happen. One, we need to actually hold everybody accountable, right? There should be bilateral accountability. You're accountable for giving the funds that you promised to give. And the governments are accountable for actually holding themselves responsible to actually match the funding. Because at the end of the day, charity does not lead to prosperity. It may heal some pains at the short term, long term, it creates dependency. The second thing that has to happen, honestly, this is where most of the work I've done in Nigeria and Ghana, is that we have to really co-define the problem. When somebody defines a problem for you and they come up with the solutions, you don't own it. And ownership is everything. Again, Chino Achebe put this very well. Do not enter your house through another man's gate. Because the moment you do that, what happens is you begin to own the problem that's not your problem. So it's not enough for me to say we have poor health systems in Nigeria. It's for Nigeria to appreciate what nature of the health system they have. And then it's for me to appreciate how we can help solve that problem. Because if it is true, then we shouldn't be having this problem today. And then finally, when you look at collaboration between African scientists, man, that is the most disappointing thing I've seen in my entire career. Elsevier did a study between 2002 and 2012 to look at the research output in Africa. We doubled our research output from 1% to 2%. As if that wasn't bad enough. If you look at the collaboration, 79% of the collaboration is from the north, global north, to the global south. When you take West Africa, the collaboration between scientists there, you guys ready for this? 0.2%. I think the new funding models must begin to look at how we can create collaborative work amongst African scientists and leaders. Because at the end of the day, Africa owns it. And today in Africa, I'm going to throw a challenge to all the African billionaires. This is a lived experience. We need to claim this space. They need to really own this space. At the end of the day, if you don't own it, how do they say it? I think if 5 people own a dog, that dog is going to starve. So the reason we're seeing what we see today is because the donor partner groups, USAID, all of the other funding agencies, they own the African problem. The problem is you don't know who is feeding the dog, because one may feel that, well, if we pull out USAID, maybe the EU may step up. They did not step up. They rather said they're going to reduce their funding to focus on global security. You can't blame them too much. We need to look inside and see what we can do to own the problem. I think I would argue when I sat on the Fogarty board that every grant that we achieve, that we send out there, must be owned by the African scientists. I think it's important for us to begin to think about this sense of ownership and share the accountability bilaterally. So we have work to do.
We have work to do, and we're so glad that we're working with people like you, Prof, and people like Anna. Let's go to Anna for a response. Anna.
Thank you, Phil, and thank you, Prof. Oludunga, for your words. I want to reiterate, I also am in complete alignment with you about the need for the ownership to be here. I say here, I'm in South Africa right now, but on the continent, that's fundamentally the most important aspect of where we are to be headed going forward. I also wanted to pinpoint the point that you made about accountability. You talked about the accountability bilaterally with different partners. I also want us to think about how we're being accountable to the populations that we are to serve in public health, the local organizations, the citizens of the many countries. I think one of the downsides of, I think, my last 20 plus years that I saw in our work that we could have done a much better job is relating to the people's needs. As you discussed before, when you have outsiders saying, here's your problem, here's how we're going to solve it, where have we really engaged local communities in the dialogue about what they need to see and want to see in their communities? If you don't touch people where they are, whatever comes to help them will not have the same type of like you were saying before, ownership or even a sense of responsibility for care and importance and priority. Um, I was speaking to a colleague that was working for another institution recently, and what we've seen in a lot of the structures of our institutions has been we look at the disease burden, we come up with the solutions, and then we ask those potential solutions that we created. But like you talked about earlier, the co-creation space, not just government, but private sector, local organizations, individuals who are impacted by the different health crises that we've faced or challenges that we're confronting. So I think there is definitely, I would agree that the importance of creating the space and having the ownership taken on by the countries themselves, designing, co-creating the solutions, identifying those problems as well. I also wanted to challenge us too about, you gave a great example of the collaboration at the university levels, 70% versus 2% on the continent of how we're sharing information. We need to speak more about who's doing what and positively. You know, I wanted to say, I know you said you didn't want to name certain countries, but I think part of our problem also is that we don't know enough about what we're doing on the continent, you know, and let me just say that for what I've been looking at, even in Nigeria with the collapse of USAID, I understood that they absorbed approximately 28,000 healthcare workers who were formerly paid by USAID. That's important. That shows that there's a level of commitment and
Mhm.
responsibility being taken on by the Nigerian government, by the sector and the health sector, that other countries should hear that that's happening. We see also what's happened in Rwanda with the amazing data, the AI platforms that they've created in their new data hub. And I think we need to hear about those stories and celebrate the accomplishments. There's so much negativity about what's happening on the continent. Actually move forward. We have to know that we can and have done so. We need those examples. And they need to be seen on I think on a regular basis so that we can demystify the ideas that dependency only is what's in the need of the continent. Things are being created as we speak. The other point I would add too is I really would love to hear us talk a little bit more about how we creating space for the youth and the younger generation that's coming through to take on this work, listening to them as well. One of the things that I valued in my time working at USAID is when I was able to meet with younger folks who didn't carry the same baggage that we carry or have the same quote unquote experience, but or have a lot of experience. How can we create the spaces for young people who are interested in the public health of their own communities, of themselves, and of the world, and get them engaged, whether it's at the university level, whether it's at creating and designing their own firms that are tackling the solutions, tackling the problems and finding the solutions to whatever epidemic that we have, whatever crisis that we're facing, or the challenges of trying to create more equity in the services that are being delivered. So I would want to just reemphasize this, the importance of us telling our stories, telling our stories. And I say our as the daughter of two parents from Equatorial Guinea, my fortunate of being born in the United States and having the opportunities that I've had has allowed me to say, then let me give back. Because I could have been in several circumstances where the people that we are talking about, the communities that we are trying to help, the disease burden that we're trying to eliminate, could have had impacted me. And so I think it's really, really important that we not lose sight of the potential and to shift that paradigm. That Africa is a continent with much innovation taking place, more than I think we even realize. Our even the wealth. I know there's a question in the chat, I think, about the wealth of the continent. Um, I don't know if everyone knows how wealthy the continent of Africa is, not just in minerals, but of knowledge. And if you change that mindset, then you will be able to imagine and reimagine where you can be. So that's just
Yeah.
one additional thing I would like to add. Thanks.
No, brilliant. Thank you. Let's move to Sheila.
Yeah, such great and thought-provoking answers. I think just picking up on a few threads, one particularly around research that Prof brought up, and as we've looked at changes in NIH funding and that type of thing, and really have seen the outputs of so much money going into research, and you brought so beautifully to the front around the inequities that have happened. And I think this is an opportunity as we're going to have to self-fund research or get, corporate world, to look at ways that we really want to answer the questions that are out there. Then we need to set our own rules and not just replicate the same system. You can only be a PI if you have 4 PhDs and all of that. And the further you get away from patients, the higher you get up in that strata. I think we have to figure out how we are self-funding research that can be set up the right structures to support having the true experts there helping drive this. And that is very hard, as many people's careers have been built on an archaic structure. But now is the time, particularly those of us in the global north, who have to fight and advocate and not allow that to happen again as funding starts to even flow again for some areas, because it's a broken system that we certainly don't want to replicate. I also think in terms of accountability, and we get this question all the time around, if we give funding for you, how do we make sure that the money is being used and, correctly, and corruption and all of this, which is, sitting in a place like the US is kind of a crazy hypocritical thing to be asking of us. But I think part of that is, as Anna said, really supporting civil society. That's who should be holding their governments accountable for the provision of health if we think health is a human right. So we need to do that by supporting civil society and ensuring that people have the ability to name what their problems are, as Anna said so eloquently, and how they want that fixed. People know the answers. People know what's needed. They just need support and maybe some particular technical expertise, and then to get out of the way. And I think that is the way that we can ensure that, or that money is flowing in the right way, is to put the power in the people who are receiving that care. And that, I think, is the way that we will shift how work is being done, but also what gets done when, and will be very different places depending on what those communities need and their challenges.
Thanks, Sheila. And as speakers, we all appreciate the power of the questions that people pose us, and it's people's questions that help us to formulate our thinking and the things that we go on to say the next time we stand up in public and are asked similar questions to these. And we've had some great contributions. Sion, a senior academic at the university, asking specifically about sexual and reproductive health-focused organizations. Majok Deng, who, if I'm not mistaken, is one of our graduates, asking some lovely questions there. Alejandro, Vernon asking some really deep and thoughtful questions. And we have questions from Omar in Somalia. Really grateful for people's contributions. I want to try and combine some of the questions with some of the things that you've already said. And building off Prof's advocacy for African states to define their problems for themselves and own the solutions, how do we collectively support governments and communities as they manage this transition away from aid? I'm going to come to Anna, then Sheila, and then Prof. And to Anna's point, how do we support the leadership of young people who'll be leading public health moving forward? So, Anna, Sheila, Prof, there's 2 questions there. You can take either one. You can take both. We've probably got about 10 minutes left. Anna.
I'll do it in 2 minutes. I'll take
Prof,
both.
you're going to go. Yeah,
Yeah,
go.
let me take both. The second question is a very important question in terms of youth. 60% of youth in the world today reside in Africa.
Yeah.
Think about that for a second, right? It's not how do we support them, it's how do we learn from them. So if you look at unemployment rate among the youth, so if you look, so we're all talking about health equity. I run a large institute here to do that. The fundamental, what they call the groundwater problem with health inequities, at least in the US, and I think everywhere else by WHO standard, is opportunity. If you have jobs, you can get health insurance. You can fend for your families. If you have a high education, you can do better. It's supposed to be the leveler. Although in most African countries, that's become now the basic standard, where you have people with tertiary education actually working as cab drivers. And then if you take the youth, the median age, you say in Africa we have the bulge, it's anywhere from 16 to 19 years. They are entrepreneurial in the way they're solving problems. You know, we don't need to go too far for us to find the solution. It's right there. I think we've got to figure out a way to learn from them. Because the archaic model that we have today, that's still trying to solve the whole idea of infectious diseases in primary health centers, to me, it's too archaic. Nigeria was colonial by the British colony. We have primary health centers, that's where we do most of our research, that are in rural settings that frankly nobody goes to, okay? But they're funded. They have probably, I don't know, 750 something in Nigeria, a country probably about the size of Texas, 250 million people. Nobody goes to receive care in those places anymore. We have increased urbanization. So the youth have figured it out. The power of AI and social media. We need to begin to leverage what they've done in that space. Because whether we like it or not, that is the next frontier. So the ability of the global health community to begin to harness the power of the youth in everything we do is going to become even more increasingly important. This is why I said what we've lost is the momentum to channel that. Because for the first time in the history of global health, people who wanted to go to do their doctorate in public health soared phenomenally post-COVID, but we lost that momentum. Then it comes to the issue of what do we do? How do we support governments? I think the way we support government is to take stock of what support do they need. When Africa, most of African countries achieved independence in the 60s, they didn't ask for support. They asked for Pan-Africanism. The idea that we're going to lead and we're going to be, how does Invictus say it? We're going to be really accountable for our own future. Somehow, the structural adjustment programs actually plunged most African countries into poverty. As Professor Mogalu will put it, I think it's in Rwanda there, he will say things like, Africa does not have a worldview of what it is. We need to take stock of what our worldview is. So the African governments, we need the landscape analysis of what is our worldview. Because once we understand what our worldview is, then we can begin to talk about the issue of health. As I say, people don't care what you know until they know that you care. I don't know that the global health community has truly cared deeply about what Africa needs. We keep saying we're giving help. Help to benefit whom? I think that's the most important question. So when we're talking about helping African governments, how are we helping them? Do we even understand the kind of help we're giving? Because charity is not help. Charity is just a short gap, a stop gap for a particular issue. But so that is where I would frame the issue. And I think we need to focus a lot on landscape analysis, geopolitical shifts. What have we learned? The countries who are thriving right now, what are those governments doing? And to Anna's point, can we share experiences? And then use that to understand where is help needed. And if help is needed, it has to be co-defined with the countries as well.
Hallelujah, Prof. Thank you so much. Anna, over to you, and then we'll come to Sheila.
Thank you. I carbon copy Prof's points as well. If I will start from what we can do to support, I also agree. Many countries, if not most countries, know what they need. Um, they need space to collaborate, to think through, to have like-mindeds in the room to help figure things out. But the solutions are homegrown. Um, I think a lot about how in I'm gonna say that previous ways of doing business, there was a lot of emphasis on ministries of health figuring out how to solve the problems. Well, the ministries of health don't function in a vacuum. In fact, what I think should be happening more and more is that you have ministries of health working with ministries of finance, ministries of education, ministries of agriculture, all these sectors together, looking at a more holistic way to approach these public health issues that impact all sectors. But I think the solutions, again, our homegrown solutions will be the best. Creating that space to producing the ownership and the accountability among citizenry, governments, private sector, et cetera.
But Sheila, let me bring you in and also prompt you to talk about the work of PIH with young people across the world. Sheila.
Yeah, I think if we look at activism and where things have changed and where we've had successes in moving the needle, HIV, TB, huge resurgence of all of us working together to try to eliminate TB, a curable infectious disease that's been here for so many years and is curable. I think that the mobilizing youth, and I think using, as Prof said, not the way that we organized for HIV in the 80s and 90s. That's not going to work. And if we try to recreate that and us as elders saying how to do it, that isn't going to work either. I think it is looking at how are people communicating, what are the answers that are there, and posing that and gathering groups of young people together who do have these ideas and spirit, and then letting them choose what the destination is and how they're going to get there. I think if we put our efforts around that and knowing it's going to look really different than what any of us have probably done, anybody over a certain age. And we have to be okay with that and celebrate that. And we have to be able to fund that and get out of the way. So I think that's what I would say about youth. PIH has PIH engaged chapters around the world, mostly in the US, but it's certainly growing in other areas. And a lot of that is to also put pressure on politicians in the US. They do a lot of government meetings and advocacy, and that's hugely impactful in trying to restore government funding that the US will hopefully still provide. But more importantly, it's building this global health equity movement, and that's the energy that we need and want for the future.
No, thank you. Thank you so much. And Alejandro from Mexico, I see that you're being really very engaging with your questions. I know Prof is typing an answer, and I'm just grateful to everybody for their engagement. There's some information pieces from Daniel and from David in the chat as well. But I think we have to wind this up. Anna and Prof and Sheila. I think what we're hearing here is a need to commit to dignity-based practices in global health research and a need to orient nonprofits and organizations towards health justice rather than aid. And we need states to define their own problems and their own solutions and engage the youth in being the engine of that change. I know that so many people in this group of friends today have felt resonance with what's been said by our speakers. I think if there were a prize, it would be resonance with no prosperity through charity. Prof, thank you for bringing that to us. Anna, thank you for bringing your experience working in the field, and Sheila, always your wisdom and guidance. And I'm going to hand back to Joanna just to bring together this meeting with a final note of thanks. Joanna.
Thank you so much, Professor Cotton. Thank you for moderating. Thank you for all of our distinguished panelists and to all of you who tuned in and joined us today online. As I mentioned at the top of the call, this is a three-part webinar series, so we have 2 more to come. Please do follow the University of Global Health Equity on LinkedIn and on social media platforms, as we'll soon be announcing the next date and time for our second webinar, which I'm sure you'll all be happy to hear is going to focus on health financing. So we saw a lot of questions in the chat about what we're going to do about this financing gap, and we'll aim to have a conversation on that in January of 2026. Thank you again and goodbye.
Thank you. Bye-bye.
Bye.